morning, good afternoon, and good evening to all speakers, chairs, and wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The first speaker for the session today is our Honorable Faculty from United States of America, Professor Georgery Holub. Professor Georgery is a consultant neurosurgeon at the Cleveland Clinic and Medical Director of the Brain Trauma Foundation. He leads the development of Brain Trauma Foundation Head Injury Guidelines, co-directed the development of SIBICC algorithms, and is the recipient of numerous prestigious awards for academic achievements such as Murray Goldstein Award of the National Neurotrauma Society, as well as humanitarian awards such as University Health Network Softman Humanitarian Award. We are extremely honored to have him today at our webinar, and today he'll be talking about what's new and what's new again in traumatic brain injury. The second speaker of today's session is our honorable guest from China, Professor Cheng Li Chao. Professor Ling Chao is an associate researcher in the neurosurgery at Huashan Hospital affiliated with Fudan University, Shanghai, China. He's mainly engaged in clinical and basic research on gliomas in the Huashan glioma subspecialty. He has a profound understanding and experience in functional glioma and thalamic gliomas. The main research direction in non-coding RNA in gliomas, tumor immunity, and glioma physical therapy and clinical trials of glioma immunotherapy. We are extremely honored to have him today at our webinar, and today he'll be talking about experience in the treatment of thalamic glioma. The chair for the first session today is our honorable guest from Filipino, Professor Lian Lucina. Professor Lucina is widely recognized in her expertise in neurosurgery, particularly in the area of neurotrauma and women in neurosurgery. She has numerous leadership positions. She's currently serving as the president of the University of the Philippines General Hospital, faculty and alumni of the Neuroscience UPFANS since 2021. She is also the chair of the Neurotrauma Committee of the Asian Australasian Society of Neurological Surgeons, starting from 2023. In the past, she served as vice president of the Academic Filipino Neurosurgeons from 2021 to 2022, as well as chair of the Philippine Specialty Board of Neurosurgery. We are extremely grateful for her for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty from India, Professor Krishna Kumar. Professor Krishna Kumar is a professor and head of Department of Neurosurgery at the Sri Chitra Runa Institute of Medical Sciences and Technology, Kerala, India. His clinical interests are mainly focused on functional neurosurgery. He's an invited faculty to several workshops and conferences around the world. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and President Professor Yoko Kato, I would like to welcome both speakers and chairs and the wonderful audiences to this online platform of ACNS webinar. A warm welcome to our colleague from China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. And with that introduction, I will hand over this podium to our first chair, our Professor Lucina. Professor, please.
Hello. Good evening to everyone from all parts of the world. It is indeed an honor to be here to chair this session. You have already, Professor Liu has already introduced our prominent speaker on neurotrauma, and we couldn't ask for more for somebody as an expert to speak. For he has been part of all these guidelines, especially Brain Trauma Foundation guidelines, and now he's developing a lot in collaboration with other experts and drafting several guidelines which will again affect our management and also make our patients better. So without much further ado, I would like to introduce and welcome our prominent speaker, Professor Gregory Hauriluk.
Okay, well, good morning, everyone. Thank you very much for the invitation to join you today. And what I would certainly say is that this has become a very prestigious speaking venue. I think one that's well known around the world, and really a pleasure to be able to join you. Let me just get to the start of my talk here. There we go. In thinking about what to say in such an important venue, I would say, there's a few different talks I give these days, but this is the one that I think gets the most positive feedback. And what I'm going to do today, this is a bit of a provocative talk. It certainly will frequently refer to the past in some ways that I think we're still struggling to advance in the field of neurotrauma. But I hope at the end of this talk that I've made you a bit uncomfortable and really made you think a little bit harder about some of the fundamental tenets of neurotrauma. I think that's one of the things we've maybe lost in our modern age is I think we aren't as good at creative thinking as we used to be. So let's do a little bit of that together today. So a couple things I need to plug early on. The first thing is that we're really looking to increase neurotrauma submissions to the journal Operative Neurosurgery. So if you're sitting on a paper and you think it might be appropriate for this journal, especially if it's something involving surgical management, please think of submitting something to us. And the next thing that I wanted to talk a bit about is a bit of an update from the Brain Trauma Foundation. So I think we're often criticized in neurotrauma for really compared to our colleagues in things like neuro-oncology, is really still being in the dark ages. But I don't think that's fair to say anymore. I think we've made a lot of progress. And the reality is that if you look at the Brain Trauma Foundation, I think that the Brain Trauma Foundation doesn't get enough credit for what it's brought forward. The BTF guidelines were the first guidelines ever published by a surgical specialty, and they have consistently been associated with a 50% reduction in mortality. And that is really remarkable. When you sit and think about it, if we had a drug that reduced head injury mortality by 50%, that would be a Nobel Prize. So I always find it a bit funny when we talk about guideline compliance. The bottom line is that the BTF guidelines have been extremely positive. So what has been at the heart of the guidelines? It's really been some fairly simple things. So the only thing we have level 1 evidence for is not to give steroids, and a shame in this day and age that we still see people that are getting them. But really, the BTF guidelines are a lot about resuscitation, not extremely hyperventilating patients, and feeding patients. So some fairly basic things that we think really underlie this remarkable outcome benefit that we've seen. And I think that the BTF guidelines, because of their methodologic rigor, have really been widely adopted. So here's the data, and I think what's remarkable in terms of that outcome benefit, this has been seen really anywhere in the world the guidelines have been implemented. So this is not just remote corners of the planet. This data from Gerber et al. Is from New York State. So I think that's really important to remember that these guidelines have been a good thing everywhere. And I think a real tribute to the guidelines is the fact that to be accredited as a trauma center in America by the ACNS COT, they expect compliance with the BTF guidelines. In a lot of cases, those are guidelines that provide level 3 evidence. So the fact that people have to follow even our weak recommendations, I think really speaks to the respect for our work and the very careful work that we have done over the years, many different investigators who've contributed to the BTF guidelines. I want people to know that there's many reasons to follow the guidelines. It's not, obviously the most important reason is the improved outcomes, but also understand that best care is also the least expensive care. So as all of the healthcare budgets around the world are tightening, it's predicted that if we went back to $1999, if every center in the US followed the BTF guidelines, it probably would have saved $1 billion a year in $1999. So many reasons to follow the guidelines. Subsequent to the publication of the first guidelines in 1996, it was very clear that the world wanted more of these. The next guideline that we went and tackled was actually the pre-hospital guidelines. And very pertinent to today's talk, we just published in the spring an update of the pre-hospital guidelines. And the idea here has always been that in that golden hour after a trauma, that care before people get to the hospital is extremely important. It's probable that you cannot overcome deficient pre-hospital care with exceptional in-hospital care. This has always been one of the BTF's flagship guidelines. Very pleased that we were able to update it. One of the major changes in the third edition of the pre-hospital guidelines has been the inclusion of the EPIC study. So this was a study, statewide study completed in Arizona. It involves about 20,000 patients. And what they did is they studied the implementation of the second edition of the pre-hospital guidelines. And very similar to what I told you before, this is, again, a new study that has demonstrated about a 50% reduction in mortality. And in fact, the benefit was even greater in patients that were sick enough to require intubation. So what is interesting is that people have looked at these guidelines and they said, well, you know, Greg, there's not a lot of change actually between the second and third edition. Perhaps the most important change is now, whereas there were no strong recommendations in the second edition, now 3/4 of the recommendations are strong. And what I tell people is that I see that as a very positive thing. This means that we got it right in the second edition. So our very conservative panelists picked the right things, and the literature has only further supported those in the time since the second edition was published. But there are a few pertinent changes to make you aware of. So I want people to know that just like the fourth edition, blood pressure targets now have gone up, and that's across the age spectrum. There are now new recommendations on temperature management. There's a greater focus on the motor component of the GCS, and I think we've all learned that that's really where the important prognostic information is. More focus on capnography and the importance of communication and documentation. The other thing that's really interesting, and I think for a lot of people this would be a major change, even in patients that are normoxic, that are not hypoxic, we are recommending the routine administration of supplemental oxygen in the pre-hospital environment for everyone. And one of the themes of my talk today is going to be the importance of oxygen. And I think we're going to come back to this idea repeatedly throughout this talk. And I would also draw your attention to a new recommendation on tranexamic acid that I think has been a very popular topic recently. And you might be surprised to see what we said, which is that based on 3 pretty well done trials, we actually do not think that for head injury, there should be routine administration of TXA. There may be some special populations, in particular the military, where it may be a benefit, but a careful look at those 3 studies, we did not feel that it should be routinely administered. We are in the process of wrapping up an update of the penetrating head injury guidelines. So it's very unfortunate that the world is already is currently engaged in a couple of different wars. And I'm sad to tell you that even though these have not been published, our mature draft of this is already being employed in some of those conflict zones around the world. They reached out to us for this even at the early stage of polish. What's sort of funny about the penetrating head injury guidelines is that these were not originally a BTF product. So they were done by something called the Neurotrauma Foundation that no longer exists. They very much mimic the style and structure of the typical Brain Trauma Foundation guidelines. They had a whole section on prognosis. They had been trying for 20 years to update this. They were published in a way they actually weren't that well known in the first edition. So Randy Bell, who at the time was the head of neurosurgery at Walter Reed Hospital, reached out to me and said, Greg, you guys just did the CBIC algorithms. Do you think we could do something like that for penetrating head injury? So I said, well, yeah, Randy, I think the BTF would love to take that on. We reached out to Beverly Walters and said, hey, Beverly, do you think that we could update those guidelines? Would that be okay with you? And she says, yes, Greg, you have our blessing. And there was a lot of reason to update these guidelines. So there's been a real shift in the military to blast injuries. Obviously, we know that penetrating head injury is really a problem that's fairly unique to the military, and unfortunately, mass shootings in the U.S. are now becoming fairly commonplace. But a really select sort of population of people are at risk. The other thing is, since the first edition, there's been a huge additional military experience. So 2/3 of the literature currently available is actually published subsequent to when the guidelines were published. The hallmark injury of penetrating brain injury is complex vascular injuries. And that's one of the key messages we're trying to get out. In conjunction with the evolution of endovascular techniques to treat these, really felt there was need for a paradigm shift and to disseminate some of the knowledge about managing these complex vascular lesions. And I will say that I've been in rooms full of neurotrauma experts and heard very diverse opinions on whether or not and how and when to screen for traumatic aneurysms and when and how to treat them. And we really felt that there was need to homogenize the field and get the experts on the same page in terms of what to do. So what are the key changes that will be coming? So we're talking about early and repeated screening for vascular lesions, much more aggressive treatment. What we're seeing in the military is despite the fact that soldiers are faced with higher caliber bullet wounds, those hit in the head are doing better than civilian patients. And there's differences in mechanism. We recognize that in the civilian world, there's a lot more self-inflicted gunshot injuries that have a poor prognosis. But still, the excellent outcomes in the military really made it clear that there's something we need to learn from them. We're pushing people to use angiography over CTA in many instances. Again, really focusing on endovascular management. I was always taught that you shouldn't try to coil a pseudoaneurysm because there's no wall. But in fact, the military and other experts say, no, you can coil these. You do have to watch them for potential need to retreat. But absolutely, endovascular management can be superior and can help to prevent sacrificing the parent vessel. Whereas the first edition said to give everyone with a penetrating head injury antibiotics, we've recommended being more selective. And when you look across the breadth of the BTF guidelines, we don't have that many level 1 and level 2 recommendations, but it appears that we will have a level 2 recommendation in this guideline at the time of your original surgery, trying to achieve a watertight dural closure so as to prevent a CSF leak and subsequent risk of infection. And you won't see a specific recommendation, but all of the panelists felt that with aggressive care and avoiding nihilism, a lot of these patients can do well. So that really will permeate our documents. So I think that we are moving out of the dark ages. I think we shouldn't be down on neurotrauma. I think through the guidelines, we really have made a tremendous difference in recent years. So I'm going to shift my talk a little bit here and get into the meat of it. So one of my mentors has been Ross Bullock, and Ross is now retired, but I always loved how he talked about the battle against the ICP as a noble battle where we're trying to prevent good brain from going over to the dark side. And here's a brain that we lost. So this brain died, and in fact, we have a pseudo subarachnoid sign. So just in order to window the brain to see it, the CSF artifactually appears white. So this is a patient that we lost, but fortunately we have all sorts of new equipment, new tools, new ideas that I think are helping us with the care of these patients. And very much the theme of my talk today is the fact that there's few new ideas. So something that, I find it remarkable that 50 years after we started ICP monitoring, this is still a really hot topic. It's never gone away. We really don't seem to be able to resolve issues around ICP monitoring. So I do think it's something we still need to talk about. I find it really funny that for millennia, I think human beings have recognized that after a head injury, there's something bad inside the head that needs to be released. And I don't think our ancestors understood that was pressure. But I think in some ways, perhaps our approach to head injury hasn't changed. We're still trying to let those evil spirits out. I think the other thing that's really important with intracranial pressure monitoring is that we can't study it the way that we used to. So back in the day in the 1960s, Nils Lundberg used to put ICP monitors into medical students' heads, and we just can't do that anymore. And the other thing we can't do is we can't sit back and we can't watch the ICP go up to 80 without treating it anymore. So some of these studies, before they understood the harm associated with ICP, really are classics that we need to read because we can't repeat them. And I think one of the themes here is the tremendous amount of information that we can get from an ICP trace. A current very hot topic is the idea of waveform analysis and the idea of extracting compliance information from that. One take home from today's talk, I think this is one of the most important papers ever written in head injury. And I think for a neurosurgeon, this is required reading. And I will tell you that this is a paper that reads as true today as it ever has. It speaks to modern issues, modern perspectives, was very forward-thinking and ahead of its time. And at the end of the day, this paper and Douglas Miller really have, more than anything else, led to the change in the promotion of ICP monitoring and the proliferation of it around the world. And what Doug Miller was able to do is he was able to associate high ICPs with bad outcome. That association was a bit clouded by the fact that we certainly know in head injury we have patients with low ICPs that also have bad outcomes. So it's always been hard to show things in head injury. But what's interesting is that Doug Miller argued for a couple different things. He said that intracranial pressure elevation is not just an epiphenomenon. It's not just a marker of a severe head injury. It's independently causative of injury. And I'm going to come back to that idea. The other thing that's really interesting in this paper, so as the first person that really looked scientifically at this data, he argued that perhaps the treatment threshold for ICP should be 10 millimeters of mercury. So that is quite a bit lower than any of the ICP treatment thresholds we've ever used. But I'm going to come back to this with some new data, and I think it's so interesting that he said this almost 50 years ago. So we have many new technologies now in the intensive care unit, and I often feel like I'm an orchestra conductor at the bedside because you have to judge all of these different streams of information, all of this monitoring data. So where does intracranial pressure monitoring fit in that? And the reality is I still think it's probably the most important monitor. We surveyed the CBIC panelists, and they felt that it was the single most important monitor. It remains a very important surrogate of brain health. And even if the brain pressure isn't high, it's very valuable to know in your head injury patient that the ICP is low. That patient probably can safely go for other surgical procedures. We know that there's better evidence for CPP monitoring there is for ICP monitoring, and you have to know the ICP to compute a CPP. And something that really is becoming more and more important is the issue of autoregulatory status, which will be another theme of my talk. So, here's a patient, from 50 paces away with these physiologic monitors. Here's a patient where I can see in green the ICP trace, and compare it with a red blood pressure trace. So you can see an inverse relationship between ICP and blood pressure. So this is a patient with intact autoregulation, and that's going to push us to raise the CPP target to 70 versus at other times in the patient's care. Remember, autoregulatory status can change frequently throughout a patient's hospital stay. The same patient at another time, now the patient is not autoregulating. So there's now a direct relationship between blood pressure and ICP. And we think this is very relevant to patient care. It's still understudied, but unless we put it in an ICP monitor, we're not going to appreciate this and be able to adjust CPP targets without knowing that. So a couple of really important questions, and I'm going to start pushing you a little bit and getting you thinking. So why is it that in brain death, why is there no blood flow to the brain? So is it that there's a sphincter at the base of the skull on the carotid and vertebral arteries that they didn't teach us about in medical school? Is that why the blood doesn't flow to the brain? The other question is if we strictly interpret Randy's best trip trial, is it true that ICP elevation isn't harmful? And if that's true, are we really comfortable going back to the days where ICP shoots up to 80 millimeters of mercury and we don't treat it? Is that really okay? So I hope that people would recognize that it's not okay. So ICP elevation, just like Douglas Miller said, is harmful. And here's at least how I understand it. And I think this is now increasingly agreed upon as how brain death happens. So as ICP goes up, the blood pressure is going to push against a higher pressure gradient. That's going to lead to decreased cerebral blood flow. And we all know about failure of the sodium-potassium channel pump, which is that's something that's energy dependent. And so you can imagine this as a vicious cycle that runs round and round and around until finally the ICP exceeds the blood pressure. So that is the reason that these patients don't have blood flow. It's because the pressure in the head, as a result of this vicious cycle, exceeds the blood pressure, and blood can't get into the head. So there is no question that ICP elevation is harmful when it starts to impede nutrient delivery to the brain, certainly in this most extreme example of brain death. So the question is not, is ICP elevation harmful? It's at what level is it harmful? And I think it's so funny that in neurosurgery, we've been much more reluctant to do a decompression of what really is a compartment syndrome as compared with our orthopedic surgery colleagues who have always said that too much scar is better than not enough limb. So here are the different ICP treatment thresholds that we've used in the BTF guidelines. And again, even though we're currently using the number 22, I mean, that's been debated. Is that 2 millimeters of mercury really important? There's these new ideas around personalized ICP treatment thresholds. So, are these really the best values? And again, thinking back to Doug Miller and that notion of 10, well, I think the important thing is that ICP elevation is harmful, and yes, we need to refine what we think the best ICP treatment threshold is. So this is something that I set out to do on my fellowship with Jeff Manley. So Jeff had this remarkable system set up. He built it basically on his own. And what it did is it recorded automatically all the physiologic data that would appear on a patient's bedside monitor automatically. It recorded it once a minute, which in the early 2000s was quite a remarkable thing, even though the Moberg monitor, for instance, now is at about 200 hertz. But what we were able to do is to use these very frequent physiologic measurements And I published a couple papers. So I looked at the association between blood pressure and outcome in spinal cord injury. I looked at the association between brain oxygen values with a Lycox monitor and outcome in head injury. And that was really just preparation for this, which was the holy grail. And I'm very proud to say we published it in JAMA Neurology. And this was looking at the association between ICP and outcome, really trying to refine the treatment threshold. And the important thing to understand is that there's different ways to think about a treatment threshold. Traditionally, we have looked for the value that is most statistically significantly associated with outcome. And that is probably the most harmful value. But I would encourage you to think about the fact that there are probably less extreme values that are also harmful, and we really haven't been thinking about that. So what we did with Jeff's data, we actually found almost 400 TBI patients, over 500 patients overall that had ICP monitoring. We were able to determine the patient's outcome, and we had so much data that we could associate with very high resolution specific ICP values with outcome. And I find this to be a very remarkable graph. So this is basically every patient that Jeff Manley ever treated at San Francisco General Hospital. This graph incorporates 3 million ICP measurements. And this to me is remarkable because we see a strong suggestion of a mode, but a very discrete, almost a mode within a mode. And that value falls very near 10 millimeters of mercury, falls around 8 or 9. And could this be recognizing that this is derived from patients that are sick in the ICU? So these are not truly normal control patients. But given the distribution of ICP values, is it possible that ICP values of 10 actually are normal and that maybe Douglas Miller had it right back in 1977? So to expand on this data, we separated out in dashed lines was TBI only, the solid line was all patients. It didn't matter how we looked at the data, that mode was always at 8 to 9. The other thing that was interesting is that when we looked at average values were always okay. They were always below 20. What really was more important than mean values in terms of association with outcome was a proportion of time below thresholds. So what this means is that it doesn't matter where your ICP is most of the time. Even short, brief transgressions below the treatment threshold seem to be important. And this really relates to this notion of an ICP dose. So in terms of this notion of old ideas, new again, I think what we did here is we really reproved something that had already been known. So it's long been said that ICP values are associated with survival, but there's never been an association published in terms of discriminating outcome in surviving patients in relation to ICP values. And this graph that we produced in our JAMA paper really illustrates why that is. So what we've done here is we've segregated patients on outcome. The blue patients are the ones that died, and we're looking at the time each of these patient groups spent at different ICP values. And as the literature would predict, what's interesting is a threshold of ICP of 20 discriminates dying patients from alive patients. But if you want to discriminate surviving patients, it's actually the values between 10 and 20 that seem to be important. So that is really interesting. So it may be that to try and achieve good outcomes in surviving patients, maybe it's an even lower value than 20 we need to look at. So I am absolutely not saying that you should go out and change your ICP treatment threshold based on what I'm showing you here now, but I do think in future studies, we need to consider lower treatment threshold values. Again, hearkening back to Douglas Miller in 1977. So in this paper, we did some very fancy statistics. We did something called a principal component analysis, and we looked at changes in the physiologic patterns between the pulse, the oxygenation, ICP, brain oxygen, blood pressure. We looked at how the interrelationship of those variables shifted across the ICP range. And we found there were shifts in the physiome at 19 and 24. So isn't that interesting? Because that's very close to our traditional treatment thresholds of 20 and 25. Now, the other thing that we did, we had Adam Ferguson at UCSF. The guy is a genius. He does statistics and regressions that most people can't do. So he did something called an elastic net regression with a lasso. And what that does is it looks only for very robust predictors of an effect. And what we found is that if we had to pick one single ICP value that was most strongly associated with outcome, that value actually was 19. So after age, injury type, that was actually the next most strongest predictor of outcome. And it was the same value that predicted outcome, whether we looked at all patients, just TBI patients, or even patients that had a decompression and had a craniectomy. So again, this is this traditional ICP threshold most associated with outcome, but concerned that there probably are lower values that may be important. So wanted to shift gears yet again and harken back again to my time with Ross Bullock. And there's something that really bothered me when I went to Richmond to train with Ross back when I was a third-year neurosurgery resident. And I have always been very interested in head injury, and I start to see, as I look through the textbooks, some physiology that I couldn't understand. So what I would see is these traces where blood pressure dropped and then ICP went up. And that didn't make any sense to me, because something that's this quickly reversible, well, what is that? It must be a vascular phenomenon, because brain swelling certainly wouldn't be this quickly reversible. But what is happening here? And as I look through the literature, I would often see that blood pressure goes down, ICP goes up. Well, I was always taught that you hit your head and you lose autoregulation. So you should be pressure passive after a head injury. But that's not usually what happens. When the blood pressure goes down, ICP goes up. So what the heck is going on here? And what's very, very interesting to me, so what's old is new again. The team in the 1960s, Lundberg understood what was going on here. So when he looked at these plateau waves, he was very interested in the vascular response. So what they would do is they would put a whole bunch of Geiger counters on the side of patients' heads. They radio-labeled albumin. And what was so fascinating is every time the plateau waves shot up, there was in fact an increase in cerebral blood volume, which is the exact opposite of what the Kelly-Monroe doctrine would tell us. So the Kelly-Monroe doctrine says, well, when the ICP goes up, you squish out blood. And that probably is true. We probably do squish out venous blood. But I think that what Lundberg showed is very remarkable. And I'm a bit bothered, because I think that this is very important physiology, and maybe we haven't been teaching it quite right. I think we teach all medical students, one of the most fundamental things about head injury is the Kelly-Monroe doctrine. And I'm concerned that it doesn't accurately portray a lot of the really important physiology at the bedside. So someone that I think really understood this physiology was Mike Rosner. I've never met him, but what he talked about was the vasoconstriction and the vasodilation cascades. And the idea here is that whenever the brain isn't getting enough of something that it needs, autoregulatory processes kick in, and the brain will dilate its blood vessels to try and compensate for a nutrient deficiency. Conversely, if you're able to get the brain enough nutrients, or even in excess of nutrients, the cerebral vasculature will shrink. You'll have a smaller cerebral blood volume. And we all know that if you can even, in some of these patients with poor compliance, if we can even reduce intracranial blood volume by 1 cc, that sometimes can make a huge difference in ICP. So I will tell you, as someone that has had these cascades in mind for 15 years at the bedside, I've really come to believe that these cascades are very relevant to the bedside, and I have always found them to be true. So I think if you read Rosner's work and have these principles in mind at the bedside, it will really help you in caring for these patients. So here's something that I would challenge you. If you go and look through your patient physiology, you are going to make the same remarkable observation that I did. So what's really interesting, speaking to the relevance of this Rosner physiology, so here in looking at the ICP trace in green and comparing it to the blood pressure trace in red, there's really not a relationship between the ICP and the blood pressure. But what is so interesting is if you look at the systemic oxygen saturation, it is a virtual mirror image of the ICP. And this is despite the fact that the oxygen saturation never drops below 90%. So I would put to you that the best explanation for the ICP here is a response to the brain oxygen values. It's virtually a mirror image. And what we think is happening is that the brain is perceiving a loss of oxygen tension, and it doesn't need to be formally hypoxic. It just decrease in oxygen, the brain can sense that and dilate its vasculature to try and compensate. So I have a paper that's about to be published on this topic. I think it'll provide better evidence that I have time to show here, but I think this is really important stuff. So the next thing I do want to talk a little bit about is advanced neuromonitoring, because I think that as these technologies are becoming popular, I still think that a lot of people aren't using the technologies well, and I'm hoping that some of the things I share with you today will help. One of the problems with advanced neuromonitoring is that it's not a substitute for excellent care. It's something that is there to augment excellent care. And it really matters how you use these technologies. So here's an example. So I'm a big fan of pupillometry. I think all know that the threshold for treatment is an NPI value dropping below 3. And so there was a very prestigious American institution where they bought a bunch of pupillometers. And here's an example of how to waste your money on new technology. So they had a patient whose NPI trended down, crossed below 3, and they didn't do anything. So they just sat on it. They kept checking the pupils, but they never acted on it. And finally, the NPI dropped to 0. The pupil blew at 3 in the afternoon. They fortunately gave mannitol, got the patient back. The patient ultimately did well. But what's the point of having a pupillometer? They could have intervened early in the morning on this patient, and they didn't. So the point here is that it really matters how you use these technologies, not enough just to have them. And again, I see all sorts of problems in patient care, certainly in my institution, and I would bet at your institution. So to be a bit provocative, I tell people, don't worry about buying brain oxygen monitors. First, just spend time providing good care to your patients. So don't do stupid things. These are common mistakes that I see. So when people come into the trauma bay and they have very high blood pressures, those are patients that are trying to perfuse their brains. That's a Cushing's response. So yes, I don't let the blood pressure ride higher than 200, but certainly I'll let it ride as high as 180. These are patients that are trying to perfuse their brains, and we don't want to drop that blood pressure. I see all the time that someone hits their head, they want to just give them hypertonic saline or mannitol. And we think that's a bad idea, because what we've learned from investigators in Colorado and other places, the brain doesn't like to be shrunk. So when you give the brain hypertonic saline, it will actually make its own osmoles to compensate. What that means is when you actually need to treat high ICP, you won't be able to, because the brain has made a bunch more osmoles to try and maintain its volume. The other thing that I see commonly is there are a lot of people that are still routinely sampling CSF lines, looking for infection. We've learned that, in fact, that just causes infection, and that's entrenched in Neurocritical Care Society guidelines. And the one thing, again, the only thing in head injury we have level 1 evidence for is not to give steroids. So I still see steroids being given, and often it's not just to treat the head injury. We see patients getting it to try and help extubation, or because they have an optic nerve injury. But the reality is that trying to avoid steroids, we have mega trials now that show that that's harmful. We want to try and avoid it. So with advanced neuromonitoring, a lot of people are concerned that when they put these in, it's just yet another reason they might be called in the middle of the night. And I have to say that my early experiences with brain oxygen monitoring and other monitors, it was almost like a religious experience to me, because what I found is that a lot of these patients were optimized by every traditional parameter. Their ICP was okay, blood pressure was okay, but it wasn't until you actually put these monitors in and you could see that the measured, once you'd measured the value was at a range, that to me was really remarkable. And I don't tweet or X or whatever it's called these days. I'm not a big technology guy, but I do think some of these new ICU technologies are extremely helpful. So, there's a lot of challenges with these technologies. So a lot of the brain probes, yes, I acknowledge they require another hole in the brain. They really increase the complexity of care. I really had to spend a year with Jeff Manley to learn to see the forest from the trees. It really does require advanced training to use these monitors and incorporate them effectively into patient care. And of course, there's just still not enough data supporting any of these technologies. But I really do think that these technologies do assist care. I will tell you that, you have to use these monitors thoughtfully. So I, very early in my career, had a patient whose parenchymal brain monitor had migrated out of the head. And that patient blew a pupil, and we wondered why it was the ICP never went up. And it's because the monitor wasn't properly placed. And so with all of these monitors, there's lots of caveats. You have to know where the tip of your monitor is. You need to make sure it's in the head. You need to know if it's in gray or white matter. So, you really have to be thoughtful with these monitors. But what I would put to you is that with advanced brain monitoring, we actually can achieve a higher level of brain optimization. And for me, when you give the brain enough of what it needs and you measure all the things it needs, you actually sleep better at night because you invoke this vasoconstriction cascade. The ICP goes down and stays down, and you tend to get more sleep. So people that are worried, you put in these monitors, you're going to get woken up more. That at least in my hands, has never panned out that way. Some brief comments about the pupilometer. So I've really come to like these. My mentor, Ross Bullock, published one of the early papers on this. And sort of like you saw on that slide with the Stanford data, these pupilometers can perhaps give as much as 15 or 16 hours warning before a pupil will actually blow. These are very sensitive. They're sensitive to 1/100th of a millimeter, which is better than any human. I really wasn't sold on pupilometry until I went to San Francisco, worked with Jeff, and saw Jeff use these in critical treatment decisions, and really slowly warmed up to these devices over the course of about 6 months. Again, here's Ross Bullock's really key paper that showed the utility of these providing early warning on declining patients. So what are some reasons to use pupilometry? So one is that we're terrible at measuring pupils, especially when pupils are small. So we're actually relatively inaccurate. So these are much more accurate than humans are. I think we all face these dark irises where it's really hard to see the pupil, so a pupilometer overcomes that. Again, this issue for early warning. In a meiotic pupil that's only going to slightly react, we get much more accurate measurements with a pupilometer. And we also need to remember the lesson that Larry Marshall taught us. Again, what's old is new again. Larry taught us that some of these temporal lobe lesions can lead to herniation and blown pupils without ever having a high ICP. So in patients like this, for me, monitoring that third nerve and uncal herniation with a pupilometer is high priority monitoring. We also need to recognize that, in some of these patients, as they're waking up from sedation paralysis, pupilometry can be very effective. And in some of these patients, after a procedure where the brain is sunken away from the inside of the skull, it can be very hard to place monitors when there's a gap between the intertable and the brain. So I fall back to pupilometry in a lot of these patients. It makes the diagnosis of brain death a lot more objective. And in fact, you can see very slight improvements in pupillary reactivity. I once saw one of my faculty members wrongly declare someone brain death. That is a very fast way to lose your hospital privileges. So a pupilometer is very precise and would help to avoid that scenario. People say, well, Greg, when do you use the pupilometer? I say, well, whenever I would check a pupil, and whatever patient I would typically want to check their pupil. And what do you do, Greg, if the NPI is trending down? I say, well, I think of it the same way as a GCS. Do I need to get a CT? Are the labs okay? All the same sorts of thoughts. A few comments about the Lycox. So I have evolved very much to being a brain oxygen focused clinician. And it's because in my hands, the last advanced neuromonitor to correct is usually the brain oxygen monitor. And so you just inherently become focused on it. And what I've learned over the years is that unless you put that brain oxygen monitor in, there's an awful lot of brains out there that are hypoxic despite having a normal ICP. And unless you put that probe in, you wouldn't know it. Once you know the brain is hypoxic, you can fix it. So in this patient, the key thing, it took us a little while to recognize, but by raising the blood pressure, we were ultimately able to fix that brain oxygen. The question is, in this modern day, do we actually need a randomized controlled trial to tell us that fixing a hypoxic brain is a good thing? And the reality is we probably do, and that data is coming. So here's Boost 2. This was not powered to show a significant benefit. It was a non-futility analysis, but it's fair to say that if the ongoing Boost 3 study is as positive as the Boost 2 study, it will overnight become a standard of care. Again, remember that a Lycox, you don't have to have a high ICP. So if I put in an ICP monitor first, the ICP is normal, it won't stop me from placing a brain oxygen monitor. And typically I put it into anyone that gets an EVD. So I would certainly direct you to the CBIC algorithms that we wrote for a really robust protocol for how to treat low brain oxygen values. But the protocol that I typically follow is first to turn up the FiO2. whereas the boost investigators will go as high as a FiO2 of 1.0. I don't go that high. I like to keep a little something in reserve in case someone becomes hypoxic. So I'll go as high as 90%. Raising the blood pressure is very effective. We can treat ICP values to values even lower than the currently accepted treatment thresholds. Something that you might not think of that can be very effective in treating brain hypoxia is actually slowing the ventilator and raising the PCO2. Of course, that is very well known for raising ICP, but it can be an effective strategy. Now the other thing is that, the other thing I like about brain oxygen monitoring is I think I've shown you some cases where it really seems like brain hypoxia is driving ICP. So now that I think we have this expanded sense of autoregulation, this Rosner physiology, for me, monitoring brain hypoxia has become even more important. And I like the fact in the pre-hospital guidelines now we have this idea of giving everyone oxygen, which I think is going to help to treat that ICP. So if we go back again to this Rosner physiology, we see that the ICP seems to be following brain hypoxia. Measuring brain hypoxia seems to be even more important. Brain hypoxia and brain oxygen monitoring is really tied to systemic insults and really helps to treat systemic insults. So if you've got a patient with a pneumonia, it can be very hard to achieve an acceptable brain oxygen value. Similarly, if you have a patient with shock, you can't keep the blood pressure up. That also can rob the brain of oxygen. So this information really can help in terms of overall optimization of the patient. Now, the other thing that I have started to do for some of these patients is there's some strategies that I can use to raise the brain oxygen that raise ICP, and it actually will cause me sometimes to do an early decompressive craniectomy. So if I have a patient with deficient autoregulation, if I raise the blood pressure, that will raise ICP. So if I remove the bone flap, that allows me a lot more latitude in raising the ICP. As well, if I raise the CO2. So I can do that much more safely if the patient is decompressed. So an early craniectomy has become a strategy that I use in some patients to try and help with that. I know I'm running a little bit tight on time here, so I'm going to start to wrap up here. The Hemodex is also a tool that I really like to use. So this is a brain blood flow monitor. I did my own investigations at the bedside to really show that it works. So here's a patient that had very poor brain blood flow. I slowed the ventilator, raised the CO2, was able to get the values up to normal. We saw the values drop when we did a balloon angioplasty. And then afterwards, we had luxury perfusion. So some of these technologies really do work at the bedside. The other thing that I like about the Hemodex is I've had the chance to beta test a brain edema function, something called the tissue water percent. And I spent a lot of time, I've published this now, looking at these brain water percent values. And I do think that they provide accurate measurements. We see this rapid rise and slow fall of brain edema when measured with this device. Portable CT can save a huge amount of time with brain compression. So here's a patient. I took him to the OR for this acute subdural. The brain was very swollen. We were worried about a contralateral hematoma. We brought the portable CT scanner into the operating room, and sure enough, we saw the hematoma expand on the other side. So this is a rare patient that I did a bilateral decompression on. We saved this patient a trip back to the ICU, from the ICU to the scanner, from the scanner back to the ICU, and then back to the OR by simply bringing the scanner into the operating room. We saved hours of brain compression. I have permission to show this photo. This patient did really well. And in fact, we have a lot of evidence saying that if we take someone out of the ICU down for a CT scan someplace else, that is harmful. And there's actually economic benefits to using a portable CT scanner. It adds capacity to the system. Have I got maybe 5 more minutes, or would you guys like me to wrap up?
Yeah, of course. Please go on.
Okay. So another technique that's very important in my practice is physiologic data display. So you've seen many times already in this talk where I can use these physiologic traces to determine autoregulatory status, patients switching again from autoregulating to not autoregulating. We can see episodes like this and go back and look at M&M rounds. What happened when that patient dropped his blood pressure and desaturated? We think at the end of the day this was a PE. Maybe we should start incorporating these physiologic traces into our M&M rounds. The other thing that I did is I reached out to Dick Moberg at the time and I said, well, if we think that treatment thresholds are important and that patients might do better when we're compliant with the thresholds, perhaps could we develop a tool to help achieve those thresholds more effectively? So I had the idea that we could create these pie graphs that would show threshold compliance for that nurse's shift or for the patient's entire hospital stay. And it's been really gratifying to see that this is really stuck. So people around the world now are using these pie graphs. It's been on the stage of multiple neurosurgery meetings. And I think it's sort of low-hanging fruit for one of the things we can do to improve outcomes. We actually tried to study this, and by using these threshold compliance pie graphs, in Utah, we were able to decrease out-of-range values by 80%. The funny thing was, once we decided to study it, shown here by that black line, our ICU was so used to trying to improve threshold compliance, we actually couldn't show a benefit because our threshold compliance was already so good. Whether we actually gave people the tool or not, it didn't matter. So this might be a new way that we can use some of this monitoring data is to try and improve threshold compliance. Lots of new tools, portable MRIs. There's a lot of stuff I couldn't talk about, but a lot is coming. We have much more to do. I think part of the problem in head injury is that I think, and hopefully I've shown you today, that a lot of the fundamentals in our field, I don't think we've got quite right. I think if we're still talking about ICP 50 years later, clearly we haven't got it all established. So this whole notion that ICP may be very dependent on oxygen values, that's sort of a new idea. It's actually long been known. Believe it or not, Doug Miller described this phenomenon once again back in the 70s, but people sort of forgot about it. If we aren't teaching the Kelly Monroe doctrine right, if some of these principles are wrong, well, how could we possibly show benefit in some of these new trials that we're doing in head injury? They're all failing. Maybe is this why? I think we've known about cortical spreading depressions and depolarizations for over 50 years, and we've largely ignored them. And I think now that we're discovering that these are important in human patients, don't have time to talk about it, but no wonder we're having trouble showing things with trials. One of my big interests is the issue of autoimmunity after head injury. So when we know that the eye is a central nervous system structure, and when the eye ruptures, we know that we can have an autoimmune response that attacks not just the ruptured eye, but also the good eye. So sometimes ophthalmologists will remove the ruptured eye to prevent that sensitization. Why wouldn't that also happen with the brain and spinal cord? So my basic science lab is showing that, well, perhaps it does, and maybe we've been overlooking this. I do not have time to go back and talk about the CBIC algorithms. I'd certainly encourage you to do that. They've been a real hit. Was really surprised that all the world experts really did things very differently, and we had a lot of trouble agreeing on things. But what I was left with was a sense that this was sort of boring. Going back and saying, when should you give mannitol? This is boring stuff. I think we need more creative thought in the field. And I think one of the important horizons is the idea of when should we provide aggressive care. And, I do want you to be aware of a couple new CBIC papers. So one looked at some consensus views on ICP motor insertion. The important finding here was that our CBIC investigators actually wanted more liberal placement of ICP monitors than what the BTF guidelines would state. So just want you aware of this paper. We recently published a survey of CBIC authors on this issue of withdrawal of care. I've been very interested in trying to develop a nihilism guard, because I think we all know neurosurgeons that are very quick to withdraw care on patients, even if they have a chance at a good outcome. So I think in neurotrauma, we have to try and protect these patients from nihilism. And what's interesting in neurosurgery, I think brain death in most parts of the world is very regimented. We have specific protocols. It's a very legal process. But simply withdrawing care, it's the Wild West. There's really no guidelines, no guidance. So I wanted to talk to the CBIC authors about trying to better inform when it's permissible to withdraw care. So I direct you to this paper that we published in the Journal of Neurotrauma. This was flagged by the editor as being a must-read paper, so very, very proud of it. And what we did is we asked opinions about withdrawal care. So I think this is not the be-all and the end-all. This is starting a discussion. But the CBIC authors said that if it was certain to be the final outcome, low severe disability might be a justifiable reason for withdrawing care. And when we asked what is the lowest chance of a bad outcome that would justify withdrawal of care decisions, it was around 80%. So this is a brand new horizon in head injury. The idea of when is it appropriate to withdraw care, I think, is a very important area for us all to work together on. So with that, I've covered a ton of ground. I hope that this has been a provocative talk, one that makes you think. I think we need a new generation of young, inquisitive minds that are going to question dogma and help us advance the field. So with that, I thank you for your time. I thank you for the invitation, and I'm pleased to take questions.
Thank you so much, Professor Gregory Horiluk, for that very comprehensive discussion for all those things that are new. Even the theory or the things that you have shaken us, like, for example, the Monroe-Kelly doctrine. You know, I agree. It's a provocative topic. And again, especially the ICP monitoring, especially in centers that, for example, in the low to middle income countries. So those are things still that are in question. So I would like to ask first if there are questions.
Yeah, I have few short questions, if I may. Prof, a very short, see how many can you answer, Prof. First is on
Yes,
prophylaxis CSF drainage despite normal ICP is common practice, whether it's good, because I think brain needs CSF. Second is the use of opioids such as morphine in the treating a head injury. Is it still indicated? Have we given enough emphasis on looking at vasospasm due to traumatic SAH in our treatment? And what do we have any monitoring of effect of atmosphere pressure on a post-decompressive crania, which don't follow Monroe-Kelly doctrine? And what is the role of looking at S100B now, whether it's still indicated?
Okay.
And the last one is on neuro rehabilitation. Have you done enough? Thank you, Professor.
Okay, lots of questions there. So let's go through them one by one. What was the first one?
First one is on for prophylaxis drainage of CSF despite normal ICP.
Yeah, so I'll be honest, I don't like prophylactic treatment. And I think if you look across the evidence at different prophylactic treatments for head injury, most of the time the evidence ends up showing it's harmful. So I do acknowledge that early CSF drainage, there is something in the 4th edition guidelines associating that with benefit. But in general, I don't like to do that. So I can share with you, I already had way too many slides. I cut out the one that shows all the osmols that the brain makes when you treat ICP. They all have names. There's mass spec data that shows all these osmols. And that's the problem, is if you treat brain swelling before you need to, when you really do need to treat it, it's going to be harder because the brain all of a sudden has all these additional osmols.
Second on morphine to the pupils, use of morphine. Opioid.
Yeah, so the big thing with, there's no question that there's a lot of drugs that have an effect on pupil reactivity. And the problem, the real thing that you have to do with the pupilometer is you have to look at a unilateral change. So if you're seeing a bilateral change, it's probably a drug effect. But if it's a unilateral change, that's much more meaningful.
Vasospasm, Professor? Are we looking enough in vasospasm?
Yeah. So what I would say, I agree with you that we're not seeing enough of it. It's very important right now in our penetrating guidelines because we think that vasospasm is a more important problem with blast injury and penetrating head injury, that exposure to a shock wave. I would say that I have probably only seen, 3 or 4 patients in my career that really got into problematic vasospasm after a head injury. And and there's other things that can cause that delayed neurological deficit, the cortical spreading depressions, depolarization. So absolutely, it's something to look at. The other thing that a lot of people forget is that it's not fair to say that no drug has ever worked for head injury. The one drug that has worked in a couple of the HIT studies, there was a subgroup analysis showing that with traumatic subarachnoid hemorrhage, men that got nimodipine had neurological benefit. Again, it was subgroup analysis, but it was replicated. So there is controversy in traumatic subarachnoid hemorrhage. So Ross Bullock would actually put some of these head injured patients with a lot of subarachnoid blood on nimodipine. Other world experts wouldn't do that. If I have a lot of basal blood, I still sometimes will do that. The problem is that can drop your pressure. That has all sorts of bad effects. But very good question. That's a very good question.
How about negative effect of atmosphere pressure on the post-decompressive crania?
Yeah, so what I think the standard answer to that now in the field, that's a very common question, is should we be monitoring pressure after we do a decompression because you've had the maximal treatment. The reality is that patients still can get high ICP, and what I find, frankly, when I decompress patients is that hemisphere will kick up a fight for 24 hours. It'll really swell out. You'll still fight high ICP, but then once you ride that patient through that, then it drops and it's never a problem again. So absolutely, we think after decompression, you still should be monitoring for ICP.
How about S100D, Professor? Marker.
Yeah, so the biomarkers are very, very interesting. And I think one of the big utilities of some of these point-of-care biomarker tests is it's going to be in austere environments in the military environment. Because right now, the part of the problem with the U.S. military is that they may have a gynecologist who's the person in the field who's looking after a head injured patient, and they have no comfort with a head injury. So they're very quick to call in a helicopter, ship the patient to an aircraft carrier where there's a CT scan for immense cost, and most of the time those scans are negative. So I think there's a lot of different ways that these biomarkers are being used. One of them is actually in discouraging need for some of those transfers. So I think that it's still early days. I think that the TRACK TBI study is trying to develop a new classification for head injury that incorporates those biomarkers. I still think that despite the strength of TRACK TBI, that's going to need further validation. But I think absolutely the idea of having like a troponin for a head injury is really valuable. I think one of the other places where it's going to be important is in orthopedic patients. So there's all sorts of patients. In TRACK TBI, they had trouble finding healthy controls. They tried to use people that had arm fractures as controls. But what they started to find is a lot of those patients had elevation of brain-specific biomarkers. So the reality is we probably have way more head-injured patients out there than what we realize. I think biomarkers are really going to be the thing that identifies a lot of these patients, and it's going to help those patients to get proper follow-up care. I think one of the single biggest things that came out of TRACK TBI was the recognition that all these concussed patients that show up and emerge never get the care that they really need, and they can have real important sequelae, lose their jobs, get divorced. They never get proper head injury care.
Last question, Professor. Indication to develop specific neurorehabilitation strategy for head injury.
That is really interesting. So in working on the penetrating head injury guidelines, we looked at rehabilitation literature, and there is very little literature. It's a shame because we really think that just like pre-hospital care is extremely important, post-hospital care is also extremely important. I think that timing, techniques, very little has been published on that. And I think again for young people in our discipline, working with our rehab colleagues to start to identify things that really are associated with outcome. That's really important stuff, and it's I think as neurosurgeons, we're attracted to the excitement of that acute trauma, but I think if we can get our young people to go to those rehab institutions and do some good research, that'll be very impactful.
Thank you very much, Professor. Professor Lucina.
Yeah, Professor, I have several questions if we still have time. Okay, you were emphasizing about nihilism, and one thing that's very devastating in neurotrauma is actually a sympathetic storm. So what can you comment if, for example, a severe TBI patient seems to be undergoing that sympathetic storm? What are the things, do you have new things that we can do for that patient?
Yeah, so the first comment that I'll make is on the issue of nihilism. And we had a symposium recently in Chicago. Chicago's looking to lead a new effort to study penetrating brain injury prospectively. We talked to the military and we said, hey, what is it that the military is doing that is getting these excellent outcomes? Is it transport time? What is it? And they said, it's nihilism. They said, if one of our colleagues is sick, they're hurt, we're going to do everything we can to help them. We're going to pull out all the stops every time. So it's that aggressive care that they really think is the most important thing. And if only we did that in the civilian world, maybe that's the most important thing. So on the issue of sympathetic storming, that's a really interesting topic because I'll tell you, the whole time that I trained in Toronto, we never acknowledged the diagnosis of sympathetic storming. It wasn't a thing we looked at. The first time I ever saw that was in Richmond. And I certainly acknowledge that, whenever we see something abnormal, we want to treat it. What I sort of fall back on, though, is I try to be lean in my care of head injury patients. And I don't treat everything that's abnormal. I really fall back to those brain monitors, because at the end of the day, that's really what I care about. I don't care, if something's 10% out of range on a monitor. I care if the brain's getting enough oxygen. So if I think that brain oxygen is the problem, and somehow if treating the storming is going to help that, yes, I'll do it. But I don't treat that necessarily independently, if that makes sense. And I'm not aware of new treatments, but I'll be honest, that hasn't been a strong research interest of mine. So there probably are new things. I just don't know what they are.
Yeah, thank you so much. Do we have still
if I may ask Professor Harlik one question. First
Please.
of all, let me thank you for this very wonderful presentation. You covered a lot, and we learned a lot, in fact, by listening to your wonderful lecture. So extremely grateful for that. Just one comment and a question, that 90% of your lecture was centered upon management of TBI, whereas around 90% of the globe, where TBI is very common, does not have an ICP monitor. So
Yes.
just the question is that is it time to have a separate guidelines issued? I request BTF to look into it, a separate guidelines for like algorithm, that if you do not have ICP monitor, the next steps to follow, because we have comprehensible evidence from the literature that the mortality is no different when you use ICP or do not use ICP.
This is a great question, and I could talk for an hour, and I'm going to not do that. But what I would say is that Raj Narayan, right from the first edition of the head injury guidelines, advocated very strongly. Raj Narayan's from India, very proud of his heritage, and he said, "Listen, we need a stratified guidelines that better meets the needs of other parts of the world that don't have American resources." And I'll tell you, even when I practiced in Canada, before I came to the Cleveland Clinic, that was also a resource-challenged environment up in Canada. So the first point is that, when we talked with the CBIC authors, everyone really felt strongly that ICP monitoring is really important. And I hope the take-home of all the things I said today is that ICP monitoring is really important. And there's a lot of reasons why those trials have failed. But a lot of us really would struggle to know how to care for a head injury without knowing all that stuff, because you learn so much from an ICP monitor. So I do hope that I've been a bit of an antidote to the best trip trials that have said the opposite, that it doesn't matter if you monitor ICP, because a lot of us really feel strongly it does. Now, the BTF, when I got involved with the BTF about 3 years ago, Jam brought me on. He wanted some fresh ideas and new directions. And one of the things I told Jam is, I said, Jam, exactly the point you made, that a lot the preponderance of head injury in the world is in places that doesn't have American resources. The BTF is not serving that population well. And Jam said, well, you know what, Greg, it's really so much more resources to come up with a stratified guideline. And everyone has a little bit of a different level of resources, so you can't come up with every possible combination. Maybe the best thing is to publish the ideal situation and then have people adopt that to whatever their local environment is. So that's traditionally been the way the BTF has done this. But I think very pertinent to the panel today. So Dr. Lucina and others are involved with a brand new BTF effort. So we've got $10 million of U.S. military funding to do 3 large new guideline projects. And the very first one that we're going to do is on this issue. So it's going to be a combat and austere environment guideline that asks those specific questions. So if you don't have a neurosurgeon, if you don't have a CAT scanner, if you don't have ICP monitoring, if you don't have an intensive care unit, how do we still provide best care to those patients? Is it worth transferring a patient if your medics are at risk of getting shot at? How badly do we need those resources? So that effort is spooling up. And we're going to have the in-person meeting in about a year from now. So stay tuned. About 2 years from now, we're going to have something for you. I would direct you to the Bootstrap protocols and the crevice protocols that Randy Chestnut and Andres Rubiano published, because I think those are excellent resources. Although they're not always evidence based, but I think they're excellent. And the other thing that I think the BTF has recognized is, even if you look within America, there's a lot of poor head injury care that happens in America. There's a lot of people in America that don't get best care. And the BTF, I think, increasingly wants to recognize that, to do what it can to try and prevent that, and to better serve neurosurgeons and patients around the world that have differing levels of resources and equipment.
Well, thank you very much. We just have an update from Professor Shubin that there are around 1,000 people who have logged in from different parts of the world to hear you live. So congratulations. Back to you, Professor Lucina.
Yeah. We still have some time for questions. Are there still questions online?
Well, we have Professor Ibrahim who is wants to ask something. Yes, Professor Ibrahim, sorry. Would you like to ask something? You can talk, Professor Ibrahim, sorry. He's not asking. Anyway, go ahead, Professor Lucina.
Okay. I want to ask, I think you mentioned, Professor Gregory, about non-invasive, clot monitoring, I think, which was already used by the military before. Is that worth getting? For example, you're in an island, and there's an accident without a scan. So would it be, for example, worth it to get that? I think it's called an infrascan or something like that.
Yeah, it is called the infrascanner. So that is a really good question, and I think we're already starting to think a bit about the 5th edition of the guidelines and what are the new topics that we're going to take on. And I think there's been such a rise. I mean, everyone has always looked for non-invasive ways of measuring ICP, but I think that if you look at optic nerve sheath diameter, I think we're closing in on a threshold for that. Waveform analysis, we've got a bunch of different things now that probably initially are going to be best used together. So we have sort of redundant efforts to look at ICP non-invasively. I think the question you've asked is really good. So I will certainly say I have never used an infrascanner, nor have I really used NIRS or anything like that. The problem with NIRS in head injury is that if you bruise your frontal lobes, which is very common, that can interfere with the NIRS signal. So but what I would say is that the people that I know that have used the infrascanner say that they quite like it. And I think the application of some of these things initially is exactly what you've mentioned, which is, probably it will help us, if it's positive, we don't really know for sure that it's positive, but probably that'll mean, yep, that's a patient we really need to go to lengths to transfer and get a proper CT. But when it's negative, those may be people that we can sit on and just monitor closely. So probably that'll be the first use. But I really hope that in the combat austere guidelines that you're part of, that there's really a critical look at the relevant literature and a decision about whether we're at that stage or not yet.
Yeah, thank you so much. Another question is that I saw in your CV that you are with developing with neuroregeneration or something like that with researches. So do you have any knowledge on brain-derived neurotropic factors that has been tested for neurotrauma? Medications.
Yeah, so there's still a huge... Yeah, there's still a huge amount of research going into neuroregeneration, and I think that at the time I did my PhD with Michael Failings, there was tremendous hope for stem cells. And I would draw people's attention to a very clever comment that I heard at the time that stem cells will always be mankind's greatest hope for neurotrauma, sort of meaning that we're never really going to realize the benefit of stem cells. We're seeing small benefits. My PhD really looked at what are the mechanisms behind that benefit. And at least in the Failings Lab model, the key cellular benefit was remyelination. The fun way that I was able to show that is I actually transplanted some cells that were taken from myelin mutant mice. And when I transplanted those cells, it was actually harmful. It actually blocked endogenous remyelination. So, what I would say is that there is still a lot of hope for neural repair by all sorts of different mechanisms. One of the challenges with trophic factors is that there's a possibility that they could be oncogenic and lead to cell divisions and overgrowth. There are some promising factors. There have been stem cells that have been genetically engineered to secrete these factors. What's interesting is that in my PhD, I looked at the trophic factor hypothesis. So I actually was able to laser capture transplanted stem cells out of rat spinal cords, and I was able to look at the trophic factors they're producing. And what was interesting, they're producing a lot of trophic factors. But when I actually looked at the tissue, it wasn't the trophic factors that actually seemed to be associated with the benefit. It was more the remyelination. So lots and lots of research still going on. I think every time there's a negative trial, the major negative trial recently in neurotrauma was the Sethrin study. So this was a much studied drug for spinal cord injury that was an inhibitor of the inhibitory environment within the injured spinal cord. And it was thought that this was a final common pathway. So all of the extracellular matrix and myelin inhibitors would be antagonized by Sethrin, and it failed. And very, very sad. That was a great hope. So we keep having to bring this new energy and come up with the new ideas. But I tell people, let's use what we have. The guidelines work for head injury, 50% reduction mortality. Let's not be sullen and say that we're not making progress, because we are. Let's use the guidelines, and isn't it wonderful people do better with them?
Yeah. So I think one of those things that have hampered in the past years for the research of neurotrauma is that neurotrauma is very heterogeneous, right? I
Yes.
mean, for example, even if you have one epidural hematoma in one patient, it's not the same in another patient. So
Yes.
for further researches, they have said that we can never get a true randomized controlled trial that's greatly designed because of these factors. Yes. So how about, like, for example, pragmatic trials, for example, like that? Yeah. So will this have value later on in our studies for neurotrauma?
Yeah, I love hearing David Wright talk about this. So David Wright was the principal investigator of the PROTECT 3 study, which, this was a very optimized, thoughtful study that learned from all the failures of the past. And, there was so much preclinical data suggesting progesterone would work, and it didn't in his study. So he's thought a lot about trial design. I think the lesson we've repeatedly learned in head injury is there's no substitute for just lots of patients. So the studies that have advanced head injury, it's been the CRASH trial, with 10,000 patients, the IMPACT studies, which now it's like 50,000 patients in the IMPACT database. There's no substitute for statistical power and sample size for overcoming that heterogeneity. That is extremely important. I will be honest with you. I did a lot of advanced statistical training when I did my PhD, and Bayesian is just a word that people use to take you out of the conversation. I don't understand Bayesian statistics. The minute someone brings up that word, my eyes gloss over. I don't know what it means. But I think that there's no question we have to do something different because what we're doing right now isn't working, and that heterogeneity is a big thing. The other lesson, again, to go back to my talk, the lesson that I learned is the importance of the environment. So when I tried to study my threshold compliance tool in an environment that was already aware of that tool, and was paying attention to it, I couldn't see a benefit because the tool, that idea was being used whether the tool was there or not. it was only by looking historically back to when we didn't even have that idea, we could see we had an 80% reduction.
Yeah.
That was huge.
Yes.
But it was because of the environment we tested it in, we couldn't see the benefit. So head energy is a very tough nut to crack.
Yeah. So okay.
Lucena, I
With
think
all
we
of
can
this,
wind up, Professor.
yeah, I'll wind up.
Quiz,
Just
yeah.
one last. I would like to ask our professor. For example, since a lot of us are listening from Southeast Asia, if you are asked to rank, for example, if somebody will invest in a brain and spine center, or a neurotrauma center, what would be your top 3 priorities to acquire in a center?
Well, I won't just give you my opinion. I'll give you the opinion of the CBIC authors because we surveyed them on this. So number 1 choice amongst the CBIC panelists was ICP monitoring. Number 2 choice was brain oxygen monitoring. I don't remember what number 3 was, but the one that I would give you is the pupillometer. I have seen many times, I'll be honest, when I was in Utah, we were the second ICU in America to get a pupillometer for every bed. And it wasn't driven by the doctors. The nurses really liked it. The nurses thought that this was a superior tool. And something really dramatic happened, which was that when we embraced the pupillometers, we stopped seeing pupils blue. We would intervene when that MPI was trending down, and we stopped seeing pupils blow. So, I'm certainly of the opinion that once a pupil's blown, there's brain damage that you can't undo. If you act quickly, you can probably minimize further damage, but I think by preventing herniation, for me, a pupillometer has become an indispensable tool. No one pays me to say that, no disclosures, but those I think are my top 3 monitoring tools, acknowledging there's many others out there, many on the way.
Thank you so much, Professor Gregory. I think we have learned a lot for this ACNS webinar. So back to you, Professor Reja. Thank you again, Professor.
Thank you
for having me,
Professor. Let us move on to the next lecture. May I call upon Professor Krishna Kumar to chair the next section. Thank you, Professor.
Hello, all the faculty and participants. Let us now move on to a very interesting as well as educative aspects about the deep nuclei in the brain. As you all know, during our periods of residency or maybe early training, the tumors of the thalamus, mostly the treatment centered around taking a biopsy and then planning for some kind of adjuvant therapy based on the histopathological findings. So that was the limitation that many centers had. And of course, we used to say in functional neurosurgery, if a young neurosurgeon wants to embark on some functional neurosurgical procedures of the deep nuclei, like deep brain stimulation, the key word taught to them was that you practice stereotactic neurosurgery by taking biopsies, and then stereotactic biopsies, and of course the best target would be a thalamic glioma. So is it a limitation that the glioma is located in the thalamus? Yes, I think we will hear from Professor Chen Ling Chow the answer today, that what the thalamus holds for the neurosurgeon, as well as what are the nuclei in the thalamus which are amenable for perfect neurosurgical treatment for them. So without much delay, I think it is time for us to listen to Professor Chen. Over to you.
It's a great honor for me to share our experience in the surgical management of Thalamic glioma. I'm Lin Chao Chen from Huashan Hospital. This operation was taken in our group, Team 9C. So far as we know, thalamus is located in the center of the brain. It is connected with telencephalon and mesocephalon, and it is very important role in somatic and phagogenic and cognitive functions. So surgical classification of thalamus is divided into 6 different regions. It contains the anterior part, the lateral part, and the posterior part. And the colloidal fissure can divide into this region 4 and region 2 into different regions. And Palvinal contains 3 different regions. It contains region 4, region 6, and region 5. So its anatomy is very important for the surgery. From the posterior superior C, we can find that the thalamus is on the posterior of the cerebellum, and the colloid fissure can separate thalamus and fornix, and pineal gland and superior column is located in the middle part of the thalamus. And from the superior view, we can see after we remove the superior frontal gyrus, we can expose the lateral ventricle. We can find that this is frontal hall and body and atrium of the lateral ventricle. And we can find that colloid plexus can separate the thalamus and fornix. After we remove the colloid plexus and fornix, we can find the third ventricle here. So if we see from the inferior view, we cut the tectum, we can find the thalamus here, and perihippocampus is located in the lateral of the thalamus, and the pineal gland and the splenium is located in the posterior of the thalamus. And from middle view, we can see this is the thalamus, and hypothalamus cycles separate the thalamus and hydrocephalus. And the fornix is above the thalamus, and this is the corpus callosum, and this is the body of the corpus callosum, and this is the spleen of the corpus callosum. If we see from the lateral view to the fiber dissection, when the intercapsule was removed, we can see this is thalamus, and the anterior comminution is in the anterior part of the thalamus. This is the caudate nucleus. And the precentral gyrus and posterior central gyrus is above the thalamus. If we move to the remove the left thalamus, we can see this is the intercapsule in the lateral part of the thalamus, and this is the gene terminus. It goes along from the medulla, goes along the posterior part and the superior part of the thalamus, and terminate at the foramen maroon. And if we view the thalamus from the posterior superior view, we can see the gene terminus separate caudate nucleus and the thalamus. And this is the street terminus. This is anterior comminution. And the street terminus goes around the thalamus and terminate at the temporal hall. If we remove the thalamus, we can see the subthalamus nucleus and red nucleus, and this is memory body. If we see from the inferior view, the hippocampus gyrus and the hippocampus formation and the fornix has been removed, we can see this is the middle geniculate body and the lateral geniculate body. If we see from the middle view of the right hemisphere, we remove the splenium of corpus callosum and the fornix, we can see the polygonal of the thalamus is here, and calculum sarcos and is have the cliff, and P3 and MPC1 is located here, associated with the thalamus. After we totally remove the corpus callosum, we can see this is caudate nucleus, this is coronal radiator, and we from see from the posterior to inferior, we can first see the splenium, then we can find the pulvinar and pineal and gland. And after we remove the splenium, we also can see the temporal hall and the paleohippocampus and epithelium of the singular gyrus, and this is the atrium of the lateral ventricle. And if we see from the posterior view, and after the middle dissection, we can see the coronal radiator and the caudate tail of the caudate nucleus. So we also can see the blood supply of the thalamus. This is P1, and medial posterior carotid artery is origin from the P2 segment. It then goes around the thalamus inferior and posterior, then it goes into the third ventricle. And the lateral posterior carotid artery is origin in the P2P segment of the posterior cerebellar artery. It goes around the thalamus in the lateral and the inferior part of the thalamus. And after we explore the temporal hall, we can see this is medial posterior carotid artery. It goes around the inferior and the posterior of the thalamus, then into the third ventricle above the thalamus. And the lateral posterior artery goes lateral and inferior of the thalamus. This is a picture shows the thalamus the blood supply. We can see that in the lateral the anterior carotid artery, and the posterior lateral part is thalamic geniculate artery. Yeah, and the middle is the branch of the thalamo-formation branch, and the dorsal is the middle and the lateral branches of posterior carotid artery. So the thalamus has so many blood supplies, so it is very difficult for the perform thalamic surgery. Beside the arteries, this is a vein. In the thalamic also can so many veins. This is thalamic straight vein, and this is inferior carotid vein and superior carotid vein. All of these veins join into the internal cerebellar vein and the greater cerebellar vein of Garen. So in the surgery, we can't damage the straight thalamic straight vein and the internal cerebellar vein. Professor Turi used the new topography on the thalamus surface. In their study, they demonstrate the thalamus have 4 surfaces. This is the lateral ventricle surface, and this is the velar surface, and this is the ventricle surface, and this is the cistern surface. After we perform the frontal gyrus resection, we can see from superior to inferior. First, we can see the lateral ventricle surface. After we dissect, remove the dissect the fornix, we can export the vena surface of the thalamus. From middle view to the lateral, we can first see the third ventricle surface of thalamus. And the street manual thalamus first from the anterior commission, then around the thalamus, it terminates at the post commission. The hypothalamic sulcus separate the thalamus and the hypothalamic. From posterior view, we can see this is the system part of the thalamus. From the inferior view, we can see the captain and the tail of the caudate nucleus and the street terminus. After we remove this part, we can see the street terminus and the posterior inferior thalamus potentals. And after we remove this street terminus, we can see the posterior and the inferior thalamic peduncles. So there are 5 thalamic peduncles contain the anterior, superior, posterior, inferior, and extral capsule thalamic peduncles. So the thalamic associate with telocephalus and have a very important role in the motor sentinel. So from the axial and the column section, we can see this is the lateral ventricle surface of thalamus. This is vena surface. This is the ventricle surface. And the thalamus is most of the part is covered by internal capsule, and the anterior part of thalamus is caudate nucleus. So the white fibers is located in the lateral of the thalamus. So Professor Julie don't use the lateral approach to do this thalamus region. They perform the central approach. So he prefers the transistant and the transcloson ventricle approach. Contain anterior interhemispheric transcloson approach and the posterior transcloson approach and the theta approach and the control theta approach. And in American Professor Spectro divided the thalamus into 6 regions. We use the 6 approach for the thalamus cavernoma. This is the 6th approach of their study. From the anterior inferior thalamus, they perform the OZ approach. For the middle thalamus, they perform anterior interhemispheric transcloson approach. From the lateral thalamus, they perform contralateral transcloson approach. And for the lateral posterior inferior thalamus, they perform palatal occipital approach. And for the middle posterior inferior thalamus, they perform the theta approach. We also do some anatomy in our laboratory for the different approach. This is theta approach, this is the anterior frontal approach, this is posterior approach. In our experience, we consider the surgical approach according to the tumor arrangement and extending of the glioma, also involving the important adjacent structures. Also, we concern the genu of the intercapsule and which the relationship with the lesion also help us to do the surgical approach. So in our experience, we like to transfrontal transventricular approach because especially the lesion is located in the frontal anterior part of thalamus and it extend anterior and superior. Its advantage to this approach we can have a wider operation angle and easy to operate, and we have no frontal disconnection syndrome. The disadvantage for this approach is sometimes we should first remove some superior frontal gyrus, and after the operation, some people will suffer the epilepsy. Another approach we prefer is the superior parietal lobe approach, especially the region located in the posterior part of thalamus, and it extends from superior and posterior part. As an advantage of this approach, it can protect the speech center as well as the optical radiation fibers. The disadvantage is we also should remove some of parietal gyrus, including SLF1, SLF2, AF, and tecton. And this patient or some of these patients also will suffer the epilepsy. So for the xenometal tumors, there are maybe 2 to 5% pediatric brain tumor, and 1% of adult brain tumor population. And its grow panel including the focal and diffuse and bilateral growth panel. And the pathology of thalamus glioma, including the low-grade glioma, such as polycythal astrocytoma, diffuse astrocytoma. And the second is the high-grade glioma, including anaplastic astrocytoma and glioblastoma. And the third type is special glioma, such as epidermolysis and TNET, and so on. And the molecular driver of thalamus glioma including the H327 mutation and the LAF mutation and RDH1 mutation. The H3K27 mutation is one of the most important driver mutations. It can induce the epigenetic of change of the glioma. So the reflection, the low-grade glioma can predict improve the patient survival. Unilateral and bilateral region appears different molecular cell in time. So therefore, they have different survival profile. And the age can predict a different survival. And for fourth, prolong the duration of the symptom before diagnosis can correct with improved the survival. And the histological diagnosis is like to be important predictor of patient survival. So I will show you some example of our case. The first one is transfrontal transventricular approach. The patient is 40 years old, female. She suffered intermittent dizziness for 4 months. Here we can see there's a tumor located in the right thalamic region, and MRI shows the tumor was low in T1 and high in T2. Contrasted MRI shows the tumor was a heterogeneous enhancement. The DTI shows the cortical spine tract is located in the lateral of the lesion. So we perform the transfrontal transventricular approach using neuronavigation and electromodulator. During the operation, we found the tumor was soft. The boundary was unclear. The blood supply was abundant. And In the first stage, we expose the lateral ventricle. We can see the thalamus here. Then we, after dissect the colloidal fissure, we can see the velar surface of the thalamus. Then after exploding the middle, we can see this is the third ventricle surface of thalamus. After expose the valve interposition, we can see the internal cerebellum vein and also street thalamus vein. So I will show you the video. First, we perform the transfrontal transventricular approach. We remove part of superior frontal gyrus. Then we can see this is the frontal hall of the lateral ventricle. And we can see this is the colloidal fissure. And we first perform palisade septum ostomy, which can prevent the future hydrocephalus. Then we can expose the lateral ventricle surface of thalamus. The tumor is here. Then we dissect colloid fissure and gently export the colloid fissure, and this is the phonics. And we can see this is the velar surface of thalamus. We use BiPAP to calculate the blood supply of the velar surface of thalamus. After calculating the blood supply, we started to remove the tumor piece by piece. Now the blood supply is not rich. We perform a tumor debulking and perform the fluorescent pathology diagnosis. The pathology result is high-grade glioma. Then we use QSA to remove tumor. After debulking, we expose the third ventricle surface of the thalamus. There are many blood supply to this surface. We calculate this branch and cut it. Further, we expose the anterior part of the ventricle surface of thalamus. Here we can see the internal cerebellum vein. We use the sponge to protect this vein. Next, we also use the QSA to debulking the tumor in the anterior part. Then we separate the ICV and the tumor. And this is the straight thalamus vein. We also protect this vein. Then we move to the lateral direction because the internal capsule is located in the located here. So we carefully remove this part of the tumor. And last, we remove the posterior part of the tumor. So we subtotal resect the thalamus tumor. This is a post-operative CT scan. This is a post-operative MRI scan. Part of tumor in the posterior part was residue. This is post-operative the patient stadium. The pathology is high-grade glioma, H3K27 mutation. This is follow-up MI. The patient received radiotherapy and chemotherapy. Now the lesion was stable. I will show you the second case. We also perform transfrontal transventricular approach. The patient was the CT scan showed the tumor located in the right thalamus. MI showed the tumor was low in T1 and high in T2. Contrast MI showed the tumor was not enhancement. This is DTR navigation, shows the cortical spinal tract was outside of the lesion. We perform the transfrontal transventricular approach. First, we also remove the superior frontal gyrus and into the lateral ventricle. Then we also perform palisade septonostomy to prevent the hydrocephalus. And after into the lateral ventricle, we can see this is lateral ventricle surface of thalamus. And we also dissect the choroid feature. We export the velar surface of thalamus. Then we can the many blood supplied to the velar surface. We calculate the blood supply. After that, we perform the tumor debugging because we decrease the blood supply in this part. The blood supply of the tumor was not reached. At last, we use two-side debugging the tumor. And finally, we also expose the third ventricle surface of the thalamus and this into internal cerebellum vein. And we protect this vein. At last, we subtotal resection tumor. This is post-operative the CT scan. This is post-operative the MRI scan. Now, the third case I will show you, we perform the transsuperior parietal approach. This girl is 18 years old. She commonly intermittent headache for 1 month and unstable walking for 2 weeks. CT demonstrated the tumor located in the right thalamus region. And the T1 shows the tumor was low signal and high signal with big edema. Contrast MR shows the central of the tumor was heterogenesis enhancement. Because the tumor location in the posterior part of thalamus and it extend posterior and superior, we use the transparietal approach. This is DTI navigation. So this is our position. First, we expose the atrium of the right ventricle. Then we dissect the carotid feature and calculate the blood supply of this tumor. After that, we perform the tumor debulking. And we first remove the superior part of the tumor. Then we further use JUSA to do the tumor debulking. And last, we subtotal resection the tumor. The pathology of this case is astrocytoma, IDH Y type, H3K27 Y type. This is a video. First, we expose the atrium of the lateral ventricle. Then we see the tumor located in the lateral ventricle surface of the thalamus. We use the BiPOP to calculate the blood supply of this tumor. Then we remove tumor piece by piece. The frozen diagnosis is low-grade glioma. Then we move to the middle part of the tumor. We can see the obviously boundary of the tumor. This is the lateral boundary of the tumor. This is the anterior part of the tumor. At last, we also use the section and the QSA to remove tumor. Because the button of the tumor is near the middle brain, it is very dangerous. So we residue some tumor. At last, we subtotal resection the tumor. This is a post-operative CT scan. This is post-operative MRI scan. This is 4 months after the operation. The muscle strength of the goal is normal. Next, I will show you another superior parietal lobe approach. The patient is 28 man, suffered intimate dizziness for 1 week. The tumor was located in the left thalamus. MRI showed the tumor was low in T1, high in T2. Contrast MRI showed the tumor was osteogenesis enhancement. This tumor also extended from to the posterior and the superior. So we used the transparietal approach. This is the navigation. This is our position. First, we perform the ventricle ostomy, then expose the lateral ventricle surface of the thalamus. Then we use the biopsy, and the present pathology is high-grade glioma. Then we use the pulsar to debug the tumor. At last, we subtotal resection the tumor. The MEP and the SCP was normal. At last, we performed palisade septum ostomy to prevent hydrocephalus. This is post-operative CT scan. This is post-operative MRI scan. This is MRI before and after the operation. Next, I also show some special cases. This case is because he suffered cephalus, the patient taken the VP shunt, and then he also received the TT fields and immunotherapy. However, after that, the patient suffered headache. MRI showed the tumor have two gliomas. The first one is located in left frontal lobe. The second located in the left thalamus. The tumor was heterogenesis enhancement. This is preoperative neuronavigation. We also use the transfrontal transventricular approach. First, we remove parts of the superior frontal gyrus and export the frontal lesion. Then we remove the tumor. The frozen pathology shows a high-grade glioma. Then we located the tumor in the thalamus. We use BiPAP to calculate the blood spread of the tumor. We remove the tumor piece by piece. The blood spread was reached. At last, we subtotal resection the tumor. This is post-operative CT scan. This is post-operative MRI scan. The muscle strength of the patient was as before. I also want to show you another multiglioma. This tumor was located in the left temporal lobe and the left thalamus. MRI showed the tumor was low in T1 and equal single in T2. Contrast MRI showed the tumor was enhancement. This is TBI navigation. This patient will perform the lateral approach using transtemporal approach. We first expose the superior temporal cycles and then locating the temporal tumor. The frozen pathology is high-grade glioma. We first remove the temporal tumor. Then we expose the atrium of the ventricle and remove the tumor in Thalamic. At last, we subtotal resection the tumor. The MEP and SCP was normal. This is postoperative CT scan. This is postoperative MRI scan. And the patient pathology is GBM, IDH type. The patient received chemotherapy and radiotherapy. And the lesion was stable. So at last, I want to show you the recurrent glioma case. This patient suffered received Thalamus glioma 6 years ago, and the tumor was recurrent. This is before the first time. Shows the tumor located in the right temporal and the thalamus. And the pathology is IDH type glioma. After the operation, the patient received concurrent chemotherapy and radiotherapy. However, the tumor was recurrent, and MRI shows the calling to NA value is 5.9. This is contrast MRI. So we perform the right temporal thalamus recurrent glioma resection. At last, we total resection the tumor. This is post-operative the CT scan. This is post-operative the MRI scan. And show the contrast the tumor was totally removed. Now patient was stable. So in the last 10 years, we done many thalamus tumor. We also published some work, and in this work we show the high-grade glioma if we is surgical extend and tumor size, and the patient receive the radiotherapy and the chemotherapy can influence the tumors survive. Then we also consider the molecular change of the tumor. If the tumor have H3K27 mutations, the survival is low and shorter than the white type. Also, the patient have the TB27 mutation. It also have the shorter or survive. Make a conclusion. So, thalamus tumor is difficult to operate. So, the surgical approach depends on the tumor extension, the location of the tumor in the region of thalamus, and also associated with fiber white effects. And the intraoperative MRI can access the amount of the resection. It also provides the possibility for the new fiber tracking and rejects the neural navigation accordingly. Also, the surgery should performed using the MEP and SCP monolith. So I also want to discuss our approach. Our approach has some shortage because we don't use the nature anatomy space of the brain, and we remove part of the brain tissue, and it can suffer the post-operative seizure attack, and subdural fluid collection rate is high. So also we have our approach have some advantage. We have the excellent surgical trajectory, and the surgical angle is wider than the transcloson approach. And the To this approach, we have no post-operative disconnection syndrome and mortem. The rate is low, and we have low risk damage to the covensity, the vein draining to the superior sagittal sinus. The branch of pericarpus collusion artery complex and phonics. So thank you for your attention.
Thank you very much, Professor Chen, for that excellent deliberation on such a difficult location of CNS tumors, the thalamus. Thanks a lot. And I'm sure all of us gained a lot, especially with your insight into the 6 regions which you told us, and with emphasis on the approach, which is actually most important for the surgeon. And of course, we should use all the neurosurgical adjuncts as possible, especially the DTI, fiber tracking, integration with navigation, and of course, neurophysiological monitoring, which is very important. And I would like to ask, what will be your policy, especially in pediatric population, when they have bithalamic patients, bilateral
thalamic? We also experience bilateral thalamus glioma case. For this case, we like to perform biopsy because we can't remove this tumor totally. After the biopsy, we like to perform VP shunt for the both side of the ventricle. And then after the pathology and molecular diagnosis, we will suggest a patient to take radiotherapy and chemotherapy.
Also, in the unilateral thalamic subsets, which are the locations where you would advise the patient for more closer follow-up, in that they have more propensity to develop sequestrated ventricles, they need a CSF diversion?
In most of the time, we like to perform the palisade septum ostomy, and sometimes we also do the third ventricle ostomy. I think for long, it may be for most of the time it can prevent the hydrocephalus. However, after the tumor progressed and it becomes very large, and maybe such patient also should need the VP shunt, in my opinion.
And among the regions which you described, especially towards the posterior aspect where the geniculate bodies come, if the radiology is more suggestive of a high-grade lesion, would you consider still go ahead with a decompression or limit to a biopsy?
Pardon?
The posterolateral thalamus, especially the inferior part, the geniculate bodies are in close association. The geniculate nucleus and its relations. So,
geniculate nucleus of the thalamus tumor.
The posterior part, if the MRI is more suggestive with this advanced sequences, suggestive of high-grade nature, is it still amenable for the parietal lobule approach and decompression, or would you prefer a biopsy?
Sometimes we also suggest to join the clinical trial, such as immunotherapy, DC vaccine, and the target therapy, maybe. I also do some research for the thalamus glioma, I see some CAR T therapy target the special antibody can also maybe in future can treat this patient.
And are there any queries in the chat box? Raja,
So far, there's no question in the chat box, Professor. You may give your concluding remark, Professor.
So on behalf of all of us, let me say my heartiest wishes to Professor Chen for enlightening us. It was a very good surgical exposure, expertise of microneurosurgery to all of us. And I think all of us benefited a lot. Thank you.
Thank you.
So I think we can conclude today's session. On behalf of the Education Committee of the ACNS and President Professor Yoko Kato, I would like to thank both speakers of today, Professor Gregory Hollock and also Professor Ling Chao, and also chairs Professor Lin Lucina and Professor Krishna Kumar for their time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. And until we meet again on next Saturday, it is bye-bye from all of us. Thank you, Professor.